Good evening. I have the privilege to introduce our speaker today, Dr. S Radhakrishnan, who was my mentor and teacher in Sanjay Gandhi Institute during my DM days. He is well known in the field of pediatric cardiology as a very good interventionalist and an astute clinician. And after a stint in Sanjay Gandhi Institute, he joined the Fortis Escort Hospital in New Delhi, and where he is currently the head of the department of the pediatric cardiology. And as I told you, he is one of the best interventionalists in the field in the country today, and he can tell you when to intervene in a patient, and more importantly, when not to intervene. That is more important. When not to intervene in a patient is more important than when to intervene. So we'll listen to Dr. Radhakrishnan. Sir, please take over.
Thank you, Krishnamurthy. I'll quickly start the talk. Can everybody see this? Hello?
Yes, doctor, we can.
Okay. Now, when Dr. Parashar gave me this topic in a session for Indian Academy of Echocardiography, I was a bit surprised because this seems to be a general topic, not exactly connected to echocardiography. But then I've tried to also put in the role of echocardiography in the area of when to intervene in cyanotic congenital heart diseases. Now, the question is, how do we define? There are two groups of acyanotic congenital heart diseases. One is the group with the left to right shunt lesions, and you're all aware of atrial septal defect, ventricular septal defect, PDA. Less commonly encountered is AP window. And then, of course, we have the obstructive lesions, which are predominantly aortic stenosis, pulmonary stenosis, and coarctation of the aorta. Now, left to right shunt lesions are some of the commonest forms of congenital heart disease encountered in daily practice. The good part about it is that most of them, in fact, all of them are easily treated and with very good long-term outcomes, immediate outcome, long-term outcome in centers which are doing only pediatric cardiac services. All these lesions which I have mentioned before should not have an overall mortality of more than 2%. Of course, in a country like ours, where a lot of patients come to us late in the natural history, it can carry significant morbidity and mortality. The so-called 2% mortality, less than 2% mortality, are for patients who present to us at the appropriate time. So the question is, why should we treat these group of lesions? And there is a compelling evidence to treat them because, especially with the larger defect, I'm not talking about the smaller size defects. The larger size defects, the first thing that happens to them is heart failure. And remarkably, this is not the typical heart failure that you see in adult practice. All these patients with heart failure who present to us in the first 1 year of life typically have normal ventricular function. You must have heard about heart failure in anemia, thyrotoxicosis, AV fistulas. So, congestive heart failure with left to right shunts actually fall under the same category. If you do, and the child might be in gross heart failure with all the symptoms of heart failure, but if you do the echo, you will see that the ventricular function is normal. Ventricular dysfunction in these group of patients develop much later in life. So it is not a feature, ventricular dysfunction is not a feature, unless, of course, it is associated with other comorbid lesions like aortic stenosis or coarctation. So ventricular dysfunction is not a feature of pure left to right shunt unless it is later in life. And then, of course, a feared complication of pulmonary hypertension, pulmonary vascular diseases, and the sequelae, which I will talk to you about in much more detail about this. And finally, if you leave it untreated, they develop cardiac arrhythmias. And it is said that sudden cardiac death is one of the most common cause of death in adult life in lesions which are being untreated during their lifetime. So this is a sort of a chart which I am showing you, that when you have a left to right shunt, you have increased pulmonary blood flow. The pulmonary blood flow is more than the systemic blood flow. As a result of this, three things might happen. One is there will be increased fluid in the lungs, decreased lung capacitance, as a result of which you will notice that the baby is tachypnic, has difficulty in increased work of breathing, and subsequently all the consequences of poor feeding, inability to gain weight, and all these sequelae occurs because of this. There is also an increased venous return to the left side of the heart, which increases the left ventricular end diastolic pressures, the left atrial pressures, and of course, that increased LVEDP and LA pressure will lead to again tachypnea and increased work of breathing. It also leads to increased left ventricular dilatation and the so called eccentric hypertrophy. Then, of course, you have increased sympathetic simulation. These patients are invariably tachycardic. Now, one has to remember that if you don't treat a large left to right shunt, not all of them go on to develop Eisenmenger physiology. Many of them, in fact, I would say the majority, if they are untreated, would die at this stage of the natural history because of heart failure. And when there is increased fluid in the lungs, they are prone to increased infection. Not uncommon to see these patients coming to you in the emergency with pneumonia, sepsis, and all these things. So most of them die during this phase. They don't go, everybody don't go on to develop Eisenmenger or pulmonary vascular disease. The next stage would be a prolonged left to right shunt will cause persistent exposure of the pulmonary vasculature to high flow and pressures, and then structural changes starts developing in the pulmonary vasculature, initially medial hypertrophy, intimal proliferation, where at this stage the PAH may still be reversible. But then subsequently, progressive changes starts occurring with fibrosis and then obliterative changes in the arterioles and capillaries. These changes become irreversible, and finally, later in life, in the early adolescent and adult life, they go on to the full blown Eisenmenger syndrome. Therefore, timing of corrective surgery is critical for the prevention of pulmonary vascular obstructive disease or pulmonary hypertension, which is actually the biggest killer later in life. In the early life, it is heart failure, and later in life, the ones who survive will die much later in life of pulmonary hypertension and pulmonary vascular obstructive disease. So, one of the European registries looked at the prevalence of PAH in adults, and you will see that ASD has the lowest incidence. I will talk to you about it. And then VST, AVST, and if you notice, AV canal defects and AP windows universally develop Eisenmenger syndrome if it is left untreated and if they survive for later on in life. So, has our understanding of pulmonary vascular obstructive disease changed? It has. And it is all because of some landmark studies by pioneers like Jesse Edwards, Rabinovich, Sheila Haworth, etc. You still keep seeing them, not Edwards and Rabinovich, but you still see Sheila Haworth talking of pulmonary hypertension, and also not only in congenital heart disease, but also in the adult varieties of pulmonary hypertension. They used to do a lot of lung biopsy studies in patients of ventricular septal defect, AV canal defect, transposition with ventricular septal defect. And they noticed that besides changes in arteriolar muscle and endothelium, which I was talking about, they noted a decrease in the arteriolar bed, that is, the volume of the arteriolar bed in lung biopsy specimens were markedly reduced, what they call as the grade C changes. And now, if you look at this, they notice grade C changes as early as 6 months in patients of simple ventricular septal defect, and much more earlier. Some of them showed to be having grade C changes in atrioventricular septal defect and TGA as early as 3 months of life. So clearly, this has completely changed our outlook as far as treatment of these lesions are concerned, because the overall concern is to prevent pulmonary arterial hypertension, which actually, if you look at it in the Western population, one of the commonest cause of pulmonary hypertension in the setting of congenital heart disease are patients who have been previously treated for congenital heart disease. They don't see Eisenmenger, etc., untreated congenital heart disease. They have actually stopped seeing them. I'm not saying they don't see them, but it has become very rare. But what has taken over are patients who have been treated for congenital heart disease and they have persistent pulmonary hypertension. So, what is the difference between what we call in the behavior of pre-tricuspid and post-tricuspid shunts? Pre-tricuspid shunts, for your information, includes ASD, and there are other lesions like which I'm not going to talk about. But post-tricuspid shunts include, of course, VST, PDA, AP window. The other lesions are all included in the post-tricuspid shunt. ASD is a pre-tricuspid shunt, which means that it occurs before the tricuspid valve. So I'm going to talk about large defects. We are not very much concerned for small defects because they don't develop Eisenmenger or they don't develop pulmonary hypertension. I'm not going into Eisenmenger because that's a very late phase. We are more concerned with PAH and pulmonary vascular disease. So in precuspid shunts, regression of pulmonary artery pressure in the neonatal period and later gradual endothelial damage occurs in PVOD. So it is very, very rare to see a child with atrial septal defect having pulmonary hypertension. Uh, and of course, there is now a lot of controversy whether if you see pulmonary hypertension in childhood atrial septal defect, is it a separate disease or is it because of atrial septal defect? I'm not going into that controversy. Whereas in post-tricuspid shunt, the pulmonary bed right from the beginning is exposed to high pressures and vascular changes are noticed in the neonatal period, what we call as muscularization of the acinar arteries, which will be noticed right from the beginning. So this is a brief background about pulmonary arterial hypertension. And of course, as you know, the onus of correct referral of these lesions or of these children or babies, newborn babies, infants, children, actually is completely dependent upon the pediatric population. As pediatric cardiologists, we don't see them in the beginning. We see them only when it is referred to us. So this initial beginning of the talk is so important for a general pediatrician who first encounters the patients in the outpatient or in the hospital. So now I'm going to briefly talk about these lesions, especially AST, VST, PDA, which forms the bulk of acyanotic congenital heart disease. We have many varieties of atrial septal defect, and all these are actually defined by echocardiography. It is one of the best modalities of imaging to differentiate these various varieties of congenital atrial septal defect, of which ostium secundum is one of the most common, then followed by ostium primum, and then we have the so-called sinus venosus defects, which we see. Now, before I actually go into evaluation, can spontaneous closures occur in atrial septal defect? It has been defined, it has been shown only for fossa ovalis defect, or what is known as the ostium secundum AST. And it is said that if you see an AST less than 8 millimeters and at a much younger age, that is less than 1 year of age, then there is a good chance that many of them can close by itself, especially when it is less than 6 millimeter. The majority of them would have closed within 1 to 2 years of life. And of course, it is said that if it is more than 8 millimeters, then you have to forewarn the family that there is a very highly unlikely chance that these defects might close, and then one has to be mentally prepared for a closure in later stages of life. What are the indications for treatment? Symptomatic. Remember that in the pediatric population, it is very, very rare for an AST to be symptomatic. And it will be interesting to see how this is diagnosed, if at all it is diagnosed during childhood. Remember, approximately 30 to 40% of atrial septal defects are actually present in the adult life. So it is very interesting if you go into their history. Many of them reach the pediatrician because of cough, the so called respiratory tract infection. Somebody notices a murmur, it is diagnosed in school. So, various ways that these atrial septal defects are diagnosed during pediatric age group. It is only once they reach 30, 40s, in fact 50s, 60s, that they start becoming symptomatic. Many of the female population undergo an uneventful pregnancy. Many of them come to us with children who have actually grown up. So symptoms, usually typical symptoms like breathlessness, fatigue, cardiac arrhythmias, etc., usually seen in the adult group. When you do an echo and you see RA-RV volume overload, then of course it is an indication for treatment. They have kept it very simple. No cardiac catheterizations to calculate so-called QPQS, etc. But in the echo, simple transthoracic echo, if you notice RA-RV dilatation, it is an indication for closing the atrial septal defect. QPQS calculation and all have all been relegated to history. It is done only as a part of calculation of pulmonary vascular resistance later in life when you diagnose PAH, or when a 40-year-old patient comes to you with atrial septal defect. You have to be very careful to rule out associated pulmonary hypertension. Then, of course, even if you have a small AST, you must have all heard of PFOs causing paradoxical embolism. The indications have also been extended into, say, a 3 millimeter, 4 millimeter, 5 millimeter ASTs, which is not causing volume overload. But if a paradoxical embolism can be proven with reasonable certainty, then of course it's an indication for closure. When do you do it? Typically, electively at 3 to 4 years of age. If you look at our recommendation of Indian Academy of Pediatrics, it is said that if you think that an AST is not going to close, then you can do it anytime after 2 years of age. But the usual classic recommendations for closing an atrial septal defect is 3, 4 years of age, or what they call as before school going age. A very, very small percentage of atrial septal defect will have congestive heart failure. Many of us don't know the reason or associated pulmonary hypertension or failure to thrive. In our country, the causes of failure to thrive are innumerable: poor nutrition, not feeding well, etc., etc. So one has to be very careful when you say that the atrial septal defect is causing failure to thrive. And you have to go into very, very detailed history about their nutrition. But we do once in a while see atrial septal defect with heart failure or associated pulmonary hypertension. Then, of course, one should not wait. But this constitutes a minority of patients of atrial septal defect. Of course, when you detect them late, as I said, you need to have a cardiac catheterization to assess pulmonary vascular resistance, and one should treat it if it is in the operable range. I'm not going into the details. But remember that early closure, when I say early closure, I mean before 1 year of age, is not essential at atrial septal defect does not directly subject the pulmonary bed to systemic pressures. However, too late closures have to be avoided in order to prevent arrhythmias, PAH, and pulmonary vascular obstructive disease. This is this was a landmark study which was conducted in 1990 when we were all in the process of training, and now of course it is being criticized because did not have very large number of patients. Typically in congenital heart disease, if you look at these studies, they never contain very huge amount of patients. But now the same study, which was at that point of time considered landmark, is now being criticized for having few number of patients. They said they took two things. One is the age of the patient, and of course the pulmonary hypertension. And clearly it shows that when you're less than 11 years of age and when you don't have pulmonary hypertension, then you're going to lead a normal life. As the age increases and as the pulmonary artery pressure increases, your longevity or your percentage of survival clearly drops in these graphs. So, two things matter: one is the age of the patient, and the other is the degree of pulmonary hypertension. And both these seems to have an overall impact in the unnatural history of atrial septal defect. Uh, this was, of course, as I said, considered very landmark, and therefore this is the things which we follow. Although most of us don't wait till 11 years of age, we would operate at 3 to 6 years of age or even less than that. Uh, but this particular study took 10 and 11 years as a cutoff value. The modalities of treatment, of course, surgery was the mainstay of treatment till about 2 decades ago. They have also entered the competition because the usual method was mid sternotomy incision, leaving ugly scars in the sternum. But now they are able to do what is known as cosmetic surgery. We call them heart port surgery, where all the cannulation is done through the peripheral veins. The patient is put into bypass through very special types of very special types of techniques to put them onto cardiopulmonary bypass, use of robotics. I have seen this heart port surgery in our institution for the past 2 decades. It is applicable mainly in adolescent and adults, not in the pediatric practice because they don't have very big veins or artery to put them into bypass. And it's actually very gratifying. Only a very small scar in the submammary area. Patients are very happy, discharged within the within 6 days of the surgery, and very little stitches to be removed. So it is very, very gratifying. And our adult heart surgeons are actually practicing this on a routine basis. The only restricting factor is the size of the peripheral arteries and veins, which is actually all measured on ultrasound. They have their own cutoff, and finally, they take a decision if heart port surgery can be done. I have not seen robotics. We have read about it, but robotics I have not seen being performed to close atrial septal defect. I'm sure there would be centers in our country doing it, but it started with a big bang at our institute. But I am told that these robotics are now only used for urological surgery. Anyway, heart port is a reality which I have seen now for the past 20, 25 years now. And here, this was the most exciting part of atrial septal defect treatment, the availability of transcatheter closure devices, which first started more than 30, 40 years ago, but then finally reached a refinement in 1996, and that has come to stay. We have been using the same device, modified here and there by various companies, but this whole thing saga started in 1996. But remember that not all ASTs can be closed. First of all, it is only the fossa ovalis ASTs which can be closed, and also they should have adequate surrounding rims all over. A transesophageal echo is absolutely essential in grown-up atrial septal defect. It is said that you have to have 4 millimeter rims all around. In the pediatric population, personally for me, I would like to wait till the child is about 15 kilos or 4 years. I have not changed the indication just because a device is available in the pediatric population. You would see reports of atrial septal defect being closed at 1 year, 2 years. Personally, I feel it is not required at all, because one has to understand the natural history of atrial septal defect, and there is no reason why we should put these metal things in very young children and ask for trouble. So I would always wait till they are 15 kilos or more, or 4 years or more, whichever it is, before I refer for device closure. Now, in children, transthoracic echo is good enough to define, although in my center, personally, I always close the atrial septal defect under TE guidance. Unless the ASD looks very favorable on transthoracic echo. Remember that in pediatric population, we have a window called subxiphoid window, that is the subcostal window. That is a good window from the subcostal area is an absolute essentiality if you want to close a ASD without transesophageal echo in the pediatric population. As they grow up, the windows, the subxiphoid, subcostal windows starts becoming inadequate, and that's the time when we have to resort to transesophageal echo. These are series of images wherein I basically call this a mental 3D reconstruction of the image from 2D sections. So we start with the 0 degree, 24, 40, and then move on to about 60, 70, and then finally 90 to 100, which gives us the bicaval view. By all these series of images, we can have a mental reconstruction of how an atrial septal defect is going to look in a 3D images, because not all of us will have a 3D T probe, but actually it is not necessary. But then it has to be a very disciplined performance of a 2D echo. If you see 2D images, T images coming of atrial septal defect, I'm sorry to say most of them are nonsense. It is very difficult to actually reconstruct a 3D picture by a 2D T picture. That is what is actually necessary. So finally, this is how it should appear. You can see on the left side, this is a perfect defect to close. It has margins all around. I'm just showing you by arrow. That is the superior vena cava rim. Down below is the inferior vena cava rim. Here you have the atrial rims, which actually includes how the pulmonary vein enters. So you have a complete picture of this, and this is something which can be reconstructed by a good disciplined T images, or also in children by good transthoracic images. They have now studies which compare ASD closure by surgery and adult. This is the proof uh, of what we are doing, and they have clearly shown that the event-free survival probability is very similar to that of surgical closure. They have also shown that in an adult, probably a device closure is superior to that of a surgical closure, uh, probably because of cardiac arrhythmias and morbidity, etc. Anyway, whatever the data is, it is now here, has stood the test of time. So one should not hesitate in doing device closures. These are some of the ASDs which cannot be closed. Ostium primum defect, sinus venosus type of defect, completely out of question. And these are some series of images, which is actually a fossa ovalis defect with very deficient rims. IVC rims are deficient, SVC rims are deficient, atrial rims are deficient, aortic rim is deficient. Of course, these are areas of controversy among the interventionalists. Some of them are very brave. They would do device closures for rims which are 3 millimeters. But of course, that comes out of experience. I'm not going into the details of this. But these are some examples of echoes which has been actually shown by transthoracic echos. The upper two are what we call as the subcostal windows. And here, of course, we have the parasternal and apical windows. So by a series of cuts, we are able to actually do a mental reconstruction of a 3D picture of how an ASD is going to look. I then go on to ventricular septal defect. You know that it is one of the commonest congenital heart defect. There are various types of ventricular septal defect, perimembranous, muscular, inlet. Again, echo, 2D echo is the mainstay in defining the type of ventricular septal defect. No other investigations are required. Gone are the days when we would do angiography. There are some centers I know of who would do an MRI to define a ventricular septal defect. It can be a part of any research protocol, but not as a part of day-to-day examination. So here you see a series of echo. The top left and right are perimembranous defect. The bottom one, the one on the left and the other one on the right, are what is known as doubly committed defects, or what we call as subpulmonic defects. Those terminologies are not used anymore. Uh, so these are the ways. What is the natural history of VST? As I was already talking about the post-tricuspid shunt, CHF in large ventricular septal defects, which starts after 6 weeks of life. Spontaneous closures can occur, and it usually occurs in small or moderate defects, very rarely in large defects. Then it can lead to, in the natural history, right ventricular outflow obstructions, left ventricular outflow obstruction, aortic regurgitation, especially in the so-called outlet or doubly committed VSD. It can also occur in perimembranous defect. And pulmonary vascular obstructive disease almost always in large defect. And then, of course, infective endocarditis. This is something which you don't see in atrial septal defect, only in post-tricuspid. So spontaneous diminution of VSDs are known to occur right from fetal life to adult life. But remember that after birth, the maximum decrease or closure usually occurs in the first 10 years of life, where, and actually within that, less than 2 years of age has the highest rate of spontaneous closure. After that, it has been noticed that there is an exponential decline in the rate of closure as the age increases. So, this is a very common figure which is quoted. 75% of perimembranous VSDs close at 10 years. Remember that these are small VSDs. 83% of muscular VSDs close at 10 years, but I have marked this in bold and uh, capital letters. I mean, this thing that for large VSD, please do not wait for diminution or closure because it is very uncommon. And by the time you start waiting for it, most of them would be dead or they would have developed irreversible pulmonary vascular disease. So, when do you treat them? Symptoms typically occur in ventricular septal defect, that is heart failure, by 2 to 3 months of age. So, initially, you want to treat them with medical management with decongestive, monitor for feeding, weight gain, and if it remains large, then please close it between 5 to 6 months of age. Do not wait now for 1 year or 2 years because today the mortality and morbidity for closing ventricular septal defect, simple ventricular septal defect, not as a part of complex heart diseases, is less than 2%. You might treat them with medical management. I'll come to that again. For small ventricular septal defect, which originally used to be defined as a shunt of less than 2:1, and now they have come to 1.5:1, and no evidence of LV volume overload, typically defined by echo, there is no need to hurry and treat them. Remember that in the pediatric age group, volume overload by echo is defined by using what is known as the Z score parameters. It is easily available in the internet as what is known as the parameters, and various institutions have developed, but there is not much difference between so-called Boston criteria, this criteria, etc. So you choose one of them and then use that to define not only for VSD but for other parameters also, aortic size, RV size, etc., etc. And then if it is a small VSD, we tend to follow them up in the initial pediatric population by in 1 to 2 yearly interval. Later on, for example, if you decide not to close a ventricular septal defect at say 15 years or 16 years, there is really no point in calling them on a yearly basis. You can call them after every 5 years. Discuss with them the need for infective endocarditis prevention. Today, the current recommendation do not recommend prophylaxis for small ventricular septal defect, but one should always emphasize preventive measures. One should not forget about that because it has been shown that probably prevention is the best way of treating these patients. Good dental hygiene is the best way of counseling them for infective endocarditis, which is anyway very rare. There is a small subset of small ventricular septal defects which will need closure. Otherwise, we tend to at least follow them up till 10 years of age and then take a decision later. So, there are a group of ventricular septal defects, especially the outlet defects, what we call as the doubly committed defect, which is one of the most superior forms, which is closely related to aortic valve and pulmonary valve. Many of them are associated with aortic valve crust prolapse. And there is some controversy in this, but in general, if you notice cusp prolapse, I think you should refer them for surgical correction. These cannot be treated by devices. I'll come to it later. And then there are a group of perimembranous VSD, which can also cause aortic valve prolapse, should also be treated, although hemodynamically, unless a few of them present very late with florid aortic regurgitation. Most of these are again detected by echocardiography, quickly referred for surgery so that you prevent a dreaded complication of progressive aortic regurgitation. It is not uncommon in pediatric population to see a very small subset of patients who come to you with this ventricular septal defect, small but with severe aortic regurgitation. That is a very, very unfortunate situation to occur because you tend to wait in the initial part of the natural history or asymptomatic, completely asymptomatic. It is later on that the AR starts giving trouble. It is also said that any small VSDs which has at least one episode of infective endocarditis should be treated. Not much data on this, but these are what is known as uh, type C indications, if you want to close them. This is just a slide to show you the natural history of a small ventricular septal defect, and you can see that it is very favorable, hardly any morbidity or mortality. What is the role of medical treatment? Remember that there is only one group of drugs which are used for treatment of these patients with heart failure, and those are diuretics, furosemide or spironolactone. There are no other drugs which is going to make any difference in the natural history. And this drug too is mainly for controlling pulmonary congestion or systemic congestion. Digoxin has no role. If you look at ACE inhibitor, which is a very common prescription that we notice in pediatric this thing, if you review the literature, it is finally said that there is some evidence from 3 non-randomized trials that some children may benefit with ACE inhibitors. So that is the current situation of ACE inhibitors. In our own IAP recommendation, we have provided diuretics as a class 1 indication. Remember that again, these are for large ventricular septal defect, not for small VSDs, sometimes for moderate ventricular septal defect. Digoxin, no role. ACE inhibitor, only if LV dysfunction, which I right in the beginning mentioned, you don't see them in the pediatric population. AV regurgitation, if it is associated, and hypertension, which is again rare in the type of population that we see or evaluate for VSD. This is also an exciting area, but not as exciting as atrial septal defect. Of course, all muscular ventricular septal defect, oh, I'm very sorry, I shouldn't say all muscular ventricular septal defect, but moderate ventricular septal defect who present to you later when they are more than 6 to 8 kilos, they can be treated with the so-called muscular VSD devices. But just like perimembranous defect, all large muscular ventricular septal defect is also treated by surgery. But this will leave a small subset of patients with a moderate VSD in the muscular septum who have other features of volume overload who can be treated with this device. So one has to be very, very specific in defining the population who can be subjected to muscular VSD closures by devices. Perimembranous dominates the clinical scenario of ventricular septal defect. So we started embarking on closure of perimembranous defect. If you see this device here at the bottom right hand side, this was actually made with a lot of things which were kept in mind. Lot of research went into this, and it came with a big bang in the medical field. They call it the asymmetrical ventricular septal defect device, keeping in mind two things. One is one should not injure the aortic valve, and the other, it should not injure the conduction tissue which passes close by in the posterior-inferior margin of the ventricular septal defect. And after all this research, this was immediately withdrawn from the market because it produced unacceptable incidence of complete heart block when you compared it with surgical result. So this device was withdrawn. They came up with so-called symmetrical devices, etc., etc. But then it was left to the human beings, us as innovators, to use other devices to close these perimembranous ventricular septal defect. Devices which were not prototyped to close the perimembranous defect then started being used, and there is some data available to show that they probably produce less incidence of complete heart block. However, there are a group of pediatric cardiologists who so vehemently oppose any closure of perimembranous ventricular septal defect with a device. So there is a lot of controversy which still goes on. It is mainly because these operators have probably seen these dreaded complications of complete heart block, perforation of the aortic valve, that they are very, very hesitant and do not advocate device closures of perimembranous ventricular septal defect. So, if you look at these three devices, what I call as innovations in closing perimembranous, the company people will never ever recommend you to do that, but it is being done worldwide. So, if you look at this, this is a PDA device, this is a PDA device, this which has been recently introduced, what is known as the Konar device, they claim that it can be used for VSD closure also. So, what is the aim? The aim is to produce minimal damage to the conducting tissue over which, frankly speaking, we have no control. We don't see that conduction tissue. We cannot avoid that conduction tissue, but it is only through studies. These devices are considered soft in nature and also put less pressure on the conduction tissue. So it is being used to close these small or moderate size ventricular septal defect. Occurrence of aortic regurgitation depends on patient selection, which I will tell you is purely by echocardiography. So one can actually predict aortic regurgitation if you're not very careful. So I'll come to the echo part of it later. This is about patent ductus arteriosus, natural history, similar to that of ventricular septal defect. However, some group says that pulmonary vascular obstructive disease is probably higher in large patent ductus arteriosus compared to VSD. Incidence of infective endocarditis is very rare. Aneurysm formation may occur, very rare. Calcification is almost always seen in the adult population. The indications are for moderate and large PDAs with LV volume overload or heart failure. Again, like VSD, you have to close them early by 6 months of age or even earlier. We have been closing very large PDAs at 2 to 3 months of age when we know that it is not going to become smaller and therefore there's no point in waiting. Small PDAs with normal LV size but clinically audible will, as per current indication, requires closure. You might argue with me and say, you are willing to wait to not to close a small VSD, so why are you closing a small PDA? A very weak argument which is given is, PDAs don't close spontaneously, VSDs can close spontaneously. But technically speaking, small PDAs are those which is not causing pulmonary hypertension, it is not causing enlargement of the left ventricle, the patient or the child itself is asymptomatic, etc., etc. So if you argue against me, I have a very weak defense in these group of patients. There is a group of PDA which you see only by echocardiography. They are clinically silent. These do not require any intervention. That at least we are very clear about. So indication 1 for moderate and large PDAs is clear. Tiny echocardiographically detected PDA, no need. Although for the small PDAs, we are still going ahead and closing it. One can argue against it. The size, shape, hemodynamic, all are defined exclusively by 2D echo. Unlike ASDs, there is no role for transesophageal echo, or angiography is used only during intervention, and very rarely CT can be used if the echo windows are very poor, and of course there is no role for TE. Later on in life, you might have to do lot of things to find out whether a PDA should be closed, especially when they come to you with pulmonary hypertension. You have to do cardiac catheterization. And sometimes what we do is, since it is ideally situated, we will balloon occlude the PDA on cardiac catheterization and then recheck all the pressures and see how it behaves on balloon occlusion. I'm not going into the details of this because it doesn't involve. So what are the devices that we see? You have the ADO1, you have the ADO2, that is the first generation of devices, the second generation of devices, and then of course, as human beings, we are innovators. Remember that to close by transcatheter technique by these devices, the children should be at least weighing 6 kilos. So the question is, we cannot close the premature PDAs in small babies who are weighing 2 kilos, 1.8 kilos, 2 kilos, etc. So there is a new device available. So these are the indications. The weight should be more than 6 kilos, because remember that if you try to put in too large defects or devices, then you can have complication. I have seen these complications occur: coarctation of aorta, LPA being completely cut off. So very fine judgment is required. It's not that PDA closure is a simple procedure. One should not take it lightly. And all these patients later on need to be operated if these complications occur. There have been attempts at miniaturization of devices in small babies. This is a relatively new device which has been introduced. They call it ADO additional sizes. And we have the ability to close these PDAs in preterm babies. And the main reason is that it is miniaturized and you can gain access through smaller catheters in these small babies. We then go on to atypical type of ASDs, that is the partial atrioventricular septal defect, which I told you never closes. No devices can be used, but typically they present like atrial septal defect. So one can have the choice of closing it electively by 2 to 4 years of age. Some of them will have significant mitral regurgitation through a cleft in the mitral valve, again, all defined by echocardiography, which may require earlier treatment. I have told you in the beginning that complete atrioventricular septal defect, which includes a combination of partial atrioventricular septal defect and a large ventricular septal defect. So they will behave like a large, in fact, worse than a large isolated VSD. All have to be closed within 3 to 6 months of age. No question of catheter techniques or anything, because these group of patients have one of the highest risks of pulmonary vascular obstructive disease. Unfortunately, many of them are associated with Down syndrome. Aortopulmonary window, 100% development of pulmonary vascular obstructive disease. Very rarely you see small AP windows which we have closed one, 2 or 3 times in our practice by transcatheter devices. We use the same device like a PDA to close it, but otherwise, for practical purposes, all AP windows are closed by surgery. Let me give you a brief outline of outflow obstructions now, because they also fall under the category of acyanotic heart disease. The issues surrounding them for untreated significant outflow obstruction is an increased afterload of the corresponding ventricle, the right ventricle or left ventricle, leading to progressive ventricular hypertrophy, then can lead to subendocardial ischemia and infarction. And finally, you have seen in adult practice, many of them develop ventricular dysfunction. We also see them in pediatric practice, but not as commonly as you see them in adult practice. All these are defined by echocardiography. The three varieties of pulmonary stenosis, valvar, subvalvar, supravalvar, are all defined by echocardiography. There are various definitions of how to do it by echocardiography. A simple transthoracic echo in the majority of cases is enough to diagnose them. No need for a TE, no need for a CT or other imaging modality. Subvalvar, supravalvar can be also associated with other form of congenital heart disease. For isolated valvar pulmonary stenosis, balloon dilatation is the treatment of choice. No questions asked. Straight away they go for balloon dilatation. Whereas if you have subvalvar and supravalvar, only surgery can be helpful in this group of patients. Typically now it is said that if by echocardiography, if you have a peak gradient of more than 50, they should be subjected to treatment. Or it is also said that if you have asymptomatic with moderate PS, but right ventricular pressure is more than, these are some of the indications one can be treated. But the most common indication is that on echo, if you have a peak gradient of more than 50, remember that it is peak gradient, not mean gradient, of more than 50 millimeters of mercury, one should treat it. Excellent results by balloon dilatation. You all know about it for valvar PS. Except there is a small group of neonatal pulmonary stenosis who come to you as a very sick stage. They are duct dependent. They have a mortality of approximately 10% even now because of various reasons. You can clearly follow them up after a successful balloon dilatation. Very small group of patients will develop severe pulmonary regurgitation after a balloon dilatation. I have seen at least 2 patients who have come later in life for a pulmonary valve replacement. But remember that it is a very rare phenomenon. For aortic stenosis, again, there are 3 varieties: valvar, subvalvar, supravalvar. You have all the 3 ranges defined by echocardiography: the subvalvar type, the supravalvar type, and below one is the aortic valve, which is one of the commonest variety of aortic stenosis. The treatment, as usual, for valvar only is balloon dilatation. For subvalvar and supravalvar, it is always surgery, very similar to that of pulmonary stenosis. Here, the mean Doppler gradient is taken to be the same as you are doing it in adult practice. A mean Doppler gradient of 40, although even though they are asymptomatic, we wish to treat them, unlike in adult practice where there is still the class 1 indication is symptomatic severe aortic stenosis, although I am aware that a lot of things are changing in that category also. But We do not wait for symptoms in the pediatric population because probably they are so active in life, there is a chance of sudden cardiac death in these group of patients, unlike that of adults. So we insist that even if they are asymptomatic, a mean Doppler gradient of more than 40 is an indication for treatment. Coarctation of aorta, which is the third group of patients who come to you with obstruction, is a very, very difficult subject, even for us, because it is said that no two patients with coarctation will have the same anatomy. There is a saying that there is a saying that coarctation can never be cured, it can only be repaired. So this is just to show you the varying anatomy. The one on the left side is what we call as a discrete coarctation, and on the right side you see a very complex coarctation. So that is why it is said that no two coarctation resemble each other. I've just provided an algorithm. Remember that imaging by 2D in the majority of patients, especially in the pediatric age group, that is all that is required. Of course, if you want to do balloon intervention, you will have to do the conventional angiography. But as they go into adolescent and adult, most of them will require a CT angio in addition to define the anatomy much more clearly. This is just an algorithm for treatment of these patients. As a broad subset, I'm sorry, in the newborn and infancy, most often it is surgery. Later on, you can do balloon dilatation. And in the adolescent and adult, one can consider stenting of the coarctation. I'm sorry about this. So, starts with surgery in newborn and infants, moves on to balloon dilatation in infancy and childhood. It is said that once they reach 20 kilos, some people say 30 kilos, you can think about stenting of the coarctation. So, in conclusion, ladies and gentlemen, acyanotic congenital heart disease are one of the commonest forms of congenital heart disease. It is easily treatable. I think even a 5% risk is a bit high. Dr. Krishnamurthy would agree with me that in a good tertiary pediatric cardiac services, the lesions which I have talked about, if it is done correctly at the correct time, then the mortality should not be more than 2%. Timely treatment prevents morbidity and mortality due to heart failure and later PAH and later LVRV dysfunction. And of course, in stenotic lesions, you can prevent LVRV dysfunction if treated correctly. This is a very important slide, may not be applicable to you. When in doubt about pulmonary vascular obstructive disease, then one should not operate. Please do not rush into treating a congenital heart disease, for example, a VSD or a PDA, when you are not sure about the operability. You have to take into a lot of things into account. That is mainly for the pediatric cardiologist to decide. Clinical, X-ray, echocardiography, cardiac catheterization are all taken into consideration in decision making, because there is a feeling that the natural history of pulmonary vascular obstructive disease with a persistent defect is better than pulmonary vascular obstructive disease with the defect closed. They start behaving like primary pulmonary hypertension. We now have pH modifying drugs which are available, which may also provide clinical improvement. And now there is data to suggest that it makes difference in mortality also. And of course, we all know that pregnancy and all should be avoided. I'm not going into that topic. I'm going to briefly talk about imaging, since this is an Indian Academy of Echocardiography meeting for acyanotic congenital heart disease. Imaging is the cornerstone in treatment in these group of patients. The morphology of the lesion, hemodynamic assessment, ventricular function, all measurements, whatever is necessary, are done with a combination of 2D echo, 3D echo in a certain group of patients, and of course, transesophageal echo can also be used. Recently, there is now data available of application of tissue Doppler imaging, global longitudinal strain for more insight into ventricular dynamics, especially on follow-up in these group of patients. So there is, unlike the adults where it is deluged with information about TDI and GLS and all, it is gradually appearing in pediatric practice also, and they are being utilized in a certain subset of patients. For example, assessment of right ventricular function, etc., in the setting of acyanotic or cyanotic congenital heart disease. Imaging has a role to play in two areas in pediatric practice. One is in the cath lab for intervention. In our own cardiac catheterization lab, no intervention in congenital cath lab is performed without the availability of echo imaging. Whatever be the lesions where we are intervening, we use 2D echo most commonly, TE in some group of patients, like I mentioned in atrial septal defect, 3D echo, especially in complex lesions. For example, if you have multiple ASTs and you need to close them, then of course 3D echo is indispensable, should all be available in the lab. The assessment of adequacy of intervention, imaging of complications during the procedure is one of the biggest boon that we have got by using imaging technology in the cath lab. No more assessment of the adequacy of, say, balloon dilatation of the aortic valve or a pulmonary valve by catheter technology. It is all done in the cardiac catheterization lab. You do the balloon dilatation of, say, pulmonary valve. You assess it by echocardiography whether you have been successful in achieving the desired result. So those days have gone where we would manipulate, unnecessary manipulation of catheter or use of contrast in order to define the anatomy, because the anatomy has already been defined uh, before intervention, and then subsequently the results are known in the cath lab by the use of imaging. So that is the role of imaging in this thing. It is indispensable for pediatric intervention in the cath lab. There is another subset of patients where imaging is absolutely essential, at least in our own practice, is in the operation theater. What do we do there? We use the epicardial echo as a cornerstone of imaging in the center. We rarely use transesophageal echo. So epicardial echo gives us excellent window to look at the outflow tracts after repair, VST patches, baffles, etc. in infants or children where it is difficult to put a T into small babies are available. So epicardial window is one of the best windows that we feel. We use it daily in our OR, and we are in the process of publishing the guidelines for epicardial echo as we do it in the pediatric journal. Almost all lesions discussed above, if they are temporarily collected or treated, do not require any further investigations other than echo at defined intervals. So if you have done everything at the correct time in the follow-up period, all you require is good imaging by echocardiography to define hemodynamics, functions, etc. It is only a small subset of patients, which is actually increasing in the Western population, where you have to assess pulmonary hypertension correctly. Remember that there is no substitute other than cardiac catheterization for assessment of pulmonary hypertension. Echocardiography gives you just estimate of pulmonary artery pressure. But if that is not an issue, then there is no other required, no other things are required. So cardiac cath is restricted to late presenters, which is not uncommon in our country. During intervention, contrast injections are very restricted as the morphology is already known. And then, of course, CT imaging, MRI are all restricted for grown up congenital heart disease, where echocardiography may sometimes prove challenging. Thank you very much for your patient hearing.
Thank you, sir. Very comprehensive, exhaustive outlining of the indications and how to do it. Typically, you have all touched upon also on the natural history of many of these conditions, and it is very easy to stick in a device, especially with the currently available newer generation device. Is very easy to do, and it has become a more of a technician job. So it is not a question of how to do it and when to do it. It's a question of when not to do it. As you already pointed out, many of the conditions do not require, and that is what you highlighted. That is more important, sir, for us. Of course, you have touched upon the younger age group of ASD who do not require closure, and also some other VST which do not require. That is very important for the most of us. And there are some questions, sir. I'll pass on to you.
Yes.
There are two questions are from different person, Dr. Biswaranjan Mishra and from Professor Neelakant. Both have touched upon the rims of ASD. They have asked, should we mention the rim around the ASD in only TEE? In TTE, what are the rims and which view should be taken?
Yes, I know. I talked about it. The rims are the same; they don't change. Whether you define it by transthoracic or transesophageal. But as I mentioned, if you want to have a correct assessment of transthoracic rim, then of course the subxiphoid window, the coronal view, the sagittal view, as we call it, is very, very important. I know if you're an adult practitioner, then of course, I think these windows are not available to you in the majority of patients. But it is very easily available to us to define. I showed you some pictures of the coronal imaging and the sagittal imaging of the various rims that are defined. The rims remain the same. It depends on the type of cut that you're taking in the transthoracic, and for that, we always start with the subxiphoid window, where in the coronal section we define the atrial rims, the AV septal rims. In the sagittal view, we define the SVC rim and the IVC rim. Then we move on to the apical view, where we define again the AV septal rim, the atrial rim at the top, and then the short axis view, where we define the atrial rim behind, the aortic rim in the front. So all these are very well defined. The main Achilles heel, so to speak, so to say, is the subxiphoid window, which as an adult practitioner may not be available. And that is why I emphasized that all adolescents and adults should have a prior transesophageal echo before you embark on a device closure in the cath lab, because it can become very embarrassing in the cath lab when you come back and counsel the parents and say, oh, I'm sorry, I did a T and I found that it is not suitable. That is not acceptable, because all adolescent and adult can have a T as an outpatient. In the pediatric age group, When we are not sure about the windows or about the rims, especially in grown up children, then we clearly tell the parents, look, we have to take a decision in the cath lab because we have to give general anesthesia to these patients in order to define the rims. And it is possible that after the TE, I might back out because things don't seem very clear to me on the transthoracic echo. So, this is the protocol that we follow.
Thank you, sir. Very, very nice to touch upon that ethical aspect also. And there is another question from Dr. Biswaranjan. In adult second-M ASD with the left-right shunt on TTE, when should ASD not be closed?
Yeah, I mean, the answer is already there. There are contraindications for ASD device closure. Most important is inadequacy of rim. The second thing is if there is significant pulmonary arterial hypertension, which puts the patient into a non-operable category, that is a pulmonary vascular resistance of more than 8. A few group of operators in borderline situations, like for example, if the pulmonary vascular resistance is between 6 to 8, they would say, okay, I will close this defect, but I will use perforation in the device in order to have a small persistent hole which can provide a pop off, so to speak. That even if the pulmonary vascular resistance doesn't fall after closure, let the ASD be present, although in a much smaller size, and let it continue. It's a very complex topic, but if you're asking me the contraindications for ASD closure, then the two most important for by device, the two most important is inadequate rims and pulmonary artery hypertension, wherein the pulmonary vascular resistance precludes the closure of an ASD. That is
Thank you,
an
sir.
Eisenmenger ASD.
May I add one point in this? The recent European Society of Cardiology guidelines have mentioned that those who are the PVR is more than 5 but comes down to 3, or it does not comes down to 3, they should be they should have targeted vasodilator
Yes.
therapy and then only reassess. In other words, they are not labeled as Eisenmenger straight away. For a
Yes.
prolonged period, how long it is not clear, they should be given vasodilator and then only reassess, and that also only for perforated patch close.
Then reassess, do the
Yes.
same cardiac catheterization, calculate the PVR, and then see what happens.
Now there are a few questions on not directly related to this topic. One question is from Dr. Ishita Banerjee. Sir, can vascular rings be discussed, the role of echo?
Yes, vascular rings cannot be defined clearly by echo. The ring itself cannot be defined, but your index of suspicion is very important. In which group of patients one should go and investigate further? CT is probably the best modality to actually show you the ring, but there are certain pointers towards suspicion of a vascular ring. One is if patients have typical symptoms with a right aortic arch, and one should always suspect a vascular ring, especially when symptoms are present. Double aortic arch, of course, can be seen on echocardiography. Then you should suspect vascular rings in a patient of left aortic arch who do not have the bifurcation of the first branch, which means that the right subclavian artery is arising aberrantly. So these are certain subset of patients wherein the index of suspicion can be high, but cannot be imaged very well by 2D echocardiography. They have to be subjected to CT in order to define it. But it is at the combination of an unusual echocardiographic finding and a clinical picture which is suggestive of some compression.
Thank you, sir. Dr. Anup Pahuja has expressed his gratitude and says thanks for the lovely talk. He has one question. In preterm babies on ventilator with evolving CLD, I understand lung disease, and bidirectional flow on echo, would you consider closer or PAH modifying drugs or treatment of COLD first and then consider, I understand it is for preterm PDA. It should be giving drugs or should we consider closer to bring the baby off the ventilator?
No, the clinical scenario that you're describing, one should not close the PDA at this stage. It is only for dominantly left to right shunt where the pulmonary vascular resistance is clearly less than that of the systemic vascular resistance and an appropriate clinical setting. The patient is not coming out of the ventilator. It is a large PDA. There is pulmonary hypertension. Your drug therapy has failed. Multiple use of the so-called non-steroidal anti-inflammatory drugs, etc. That is the indication. If you try to close them at a stage when the pH is high that it is causing bidirectional shunt, I don't think one should attempt it at that stage.
Thank you, sir. Now, there is a question from Dr. Venkatesh. In a combined lesion like VST and PDA, how do we approach in management regarding surgical versus percutaneous closure?
Again, it depends on what age they present, what is the size of the lesion. Let me give you various permutation and combination. A child comes to you with a large VST and a small PDA. Would you close that PDA with a device? No, you will not. Because for the large VST, the patient has to go for surgery. And of course, the surgeon would be equally capable of closing the PDA also. So, very rarely you can have a clinical scenario wherein the child is suitable for a device closure for both the VST and PDA. There, of course, you can do it. For example, the child is our way of looking at it that the child for a VST closure should have a moderate to small defect, should be more than 8 kilos. Some people say it should be more than 6 kilos, but I take more than 8 kilo to be on the safer side. The VSD is suitable for a device closure. That means it is away from the aortic valve. And of course, the PDA is very rarely unsuitable for a device. So, how many patients would you encounter with this clinical scenario? I rarely encounter such patients who are the correct hemodynamics, the correct anatomy, and then we subject them to a device closure for both VST and PDA.
Thank you. There is another question. Can echo only be used in the presence of PAH to decide on operability?
I answered that question. It's an absolute no. Cardiac catheterization is a class 1 indication for correct assessment of pulmonary hypertension. Remember that you have lot of literatures available which says that I can calculate PVR, I can calculate pulmonary artery diastolic pressure, I can calculate PA mean pressure. Please don't use echo parameters to do all that. Today, if you have pulmonary hypertension, whether it is because of a congenital heart disease or because of primary pulmonary hypertension, cardiac catheterization is a class 1 indication. There are no substitutes for correct assessment of PAH hemodynamics other than cardiac catheterization. Also remember that there are a group of patients in which PAH has to be assessed. The so-called vasoreactivity of pulmonary hypertension has to be assessed. That can only be done in the cath lab. Remember, assessment of PA diastolic pressures, PA mean pressure by echocardiography is fought with so many problems. Also, when you are calculating PA systolic pressure by the TR velocity, you make hundreds of assumptions. One of the biggest assumptions that you make is the right atrial pressure. You just assume that because the IVC is contracting, it is collapsing, it is this size, it is all right for an OPD assessment of PA systolic pressure, but nothing more than that. I think Krishnamurthy will agree with me on this.
Yeah, I fully agree. Currently, for pH operability, so in the operability assessment, cath. But if you decide to intervene without cath in patient without pH, of course, cath is not indicated. And there is, I think there are no more questions here. So may I ask one question?
Yes.
We have had a few patients where we have closed this ASD, small ASD with the device, which they have had, not paradoxical, but they had right to left shunt on strain, just like a PFO. All these ASDs are 6 millimeter, 8 millimeters, and we took them up for TE because either ECG or echo showed some volume overload. So we thought we will decide them on the table after TE. But after putting the TE, we made just like a PFO. They are all left-right ASD. They became right-left on strain, Valsalva, and we closed them at least about nearly 8 to 10 patients. What is your opinion, sir? So in other words, should small ASD, which have purely left-right, be considered like this?
Yes, I have encountered not in a small ASD. There are two or three things. One is echocardiographic bidirectional shunt in a large ASD can be because of hemodynamics. There is some group of patients with atrial septal defect, which we have seen in our practice, is when the RV is hypoplastic. That is, the right ventricle for some reason is hypoplastic, or which has a diastolic pressure which is more than acceptable. They can also continue to shunt periodically by right to left shunt. So I wonder that by doing Valsalva, are you changing the hemodynamics transiently, which causes the ASD to also shunt right to left? That is my only worry. Otherwise, typically an ASD with normal PA pressures, normal RV size should not be shunting right to left. Now, by doing Valsalva, if you make it shunt right to left, is that proper hemodynamics? I cannot say.
But this has happened, and that hemodynamic can occur when the patient strains.
Yes, it can.
That is why we closed it.
It can occur. I agree, but whether closing it would change the natural history,
No, we are not sure. We are not sure.
We are not sure.
There are currently no more questions. Anybody have any questions? Yes, no more questions are there. Okay. As a parting remark, I would like to mention that in Suchitra, all ASD and small PDA are closed only with echo guidance. No angiography, no fluoroscopy. Yes. Nearly 80% of them do not have, absolutely zero fluoroscopy.
Yes.
And even the training for the fellows is now done like that.
Yes.
So being an echocardiography conference, I would like to mention this.
We are evolving, the techniques are evolving. For example, when we first started closing the atrial septal defect, we would define the ASD by angiography. Right in the beginning in 1996, we would go into the right upper pulmonary vein and do an angio to show the ASD. That went away. Now we are closing PDAs without any arterial access at all. Everything is through the venous access. We have not reached your stage where we would not take them to the cath lab without fluoro guidance, only by echo. But I guess these things evolve, and you can always justify the results if it is good. We have stopped doing angiography for ASDs, for PDAs. That has been given up a long time ago.
Now, currently, there are no more questions. So, shall we wind up, sir?
Yes, sure. Thank you very much. Nice seeing
Thank you,
you.
sir. Thank you, Dr. Radhakrishnan, for this exhaustive talk. And thank you for Dr. Parashar and the Indian Academy of Echocardiography for hosting this. Thank you all and good night.
Thank you.